Okay, we are live, madam. You can start.
Super. So good evening, everyone, and welcome to the Blast series where we brainstorm and learn from case-based discussions. We are having this session almost after 2.5 months. It's the first session of this year. And I'm happy that we are talking about fibroids and fertility because it's very relevant in the present time, because I think we gynecologists are faced with two dilemmas: the diagnostic dilemma and the management dilemma. So we know that myomas are the most common tumors in women which impact lives from puberty to menopause. And we have challenges in diagnosis and decision making. And in the present day, especially for well-informed patient, extensive counseling needs to be done, a detailed consent needs to be taken. And for surgeons, of course, the learning curve is very steep and there are dreaded complications and newer surgical techniques they need to be updated with. So this is the background context of why we need to talk about fibroids and fertility. So Jay, this is the case we're going to discuss. I've put in one pretty much simple, straightforward case and two quick cases where you'll just give your opinion as to how you would deal with them. So this is a 28-year-old female who came to us with primary subfertility, attempting pregnancy since 3 years, regular cycles and recent onset menorrhagia and dysmenorrhea since 5 months. Male factor normal, AMH normal, and tubes are not evaluated. Now, if you look at the ultrasound picture, Jay, can you see this video?
Yeah.
Right. So you can see here, this is the bladder on this side. This is the endometrial echo. And this patient has a posterior wall myoma and also a anterofundal myoma. The sizes are mentioned over here. She also has a very clear-cut submucous myoma over here. And there's a line diagram depicting what exactly we saw on ultrasound. And if you can see, this anterofundal myoma is not really touching the junctional zone, but the posterior wall myoma is sort of just touching the junctional zone. So with this background, Jay, these are your questions and over to you.
Yeah. So, see, I think one thing which is very important for people to understand is that fibroids are very common in practice. Okay. And it is important that clinicians understand that even patients know this thing. Okay. That fibroids are a very, very common thing. It is really not rocket science. Okay. If there is the first take home message which everybody should remember about fibroids is that they should really, really put an end to giving medical management. Okay. I mean, whatever you like, mifepristone, ulipristal, antagonist, whatever people like to give. One thing is absolutely crystal clear that those guys have a very, very limited effect. Okay. And the side effect profile of those guys is pretty big. Okay. So, and see, today, if you look at India, the cheapest thing which is available in India is talent. Okay. So if in case you can't do a surgery on your own, call somebody to get a surgery done. I guess when it comes to doing a laparoscopic myomectomy, a surgeon would not really end up charging more than 30,000 rupees as a traveling surgeon. Okay. So it's not even an affordability which is an issue. It is the mindset. Okay. So that should be the first take home point. Okay. Surely submucous fibroids have an effect on fertility, answering your first question. For that matter, any fibroid which causes distortion to the cavity has an effect as far as fertility is concerned. Okay. And one more thing, remember, if the fibroid is not distending the cavity, but it is large. Okay. For example, if it is, let's say, a 15 centimeter subserous fibroid. Okay. Not distorting the cavity. It's a large fibroid. A large fibroid, any fibroid more than 6 centimeters, I mean more than the size of the uterus, basically. A standard uterus is 6 centimeters. If the fibroid is more than 6 centimeters, you have to knock it out. It is as simple as that, as simple as that. There is no question to that. All right. So that is the answer to your second question, that does size matter in intramural fibroids, which are not cavity distorting. See, you can have a 3 centimeter intramural fibroid not doing anything, poor guy. You can just keep it on follow-up. Nothing really happens. Okay, but if it is a 7 centimeter intramural fibroid, you must remove it. Absolutely, you must remove it.
So what is your
Then come,
cutoff size?
no. If so, see, theoretically, the cutoff size is around 5 centimeters. Okay, more than 5 centimeters, better to go and remove it. That is because the size of the uterus is that much. So that is something which we have to consider. Okay, what information would you want from the person doing your ultrasound? So that is pretty simple. Best is to do a transvaginal scan, is to look at the number of fibroids, basically the size of fibroids and distance of the fibroids or indentation of the fibroids in the cavity. Okay, so a lot of these grading systems are available, grade 0, 1, 2, 3, 4, 5, 6, 7. People can try and map it on that, and it just makes some standardization into that. But otherwise, size, number, and distance from the cavity, these are the three things which you should see. Okay, important, very, very important. When you have fibroids, please rule out endometriosis on ultrasound. Okay, because fibroids and endometriosis usually would go in sync with each other. So that is just one thing which you need to keep in mind before you try to knock out anything else. Okay. When would you plan a wait and watch approach? So as I said, let's say 3 centimeter fibroid, subserous, 3 centimeter fibroid, intramural, doing nothing to the cavity. Okay. Any which ways, it does not require immediate surgical removal. Absolutely, it doesn't require surgical removal. I don't do an LDH, to be honest with you, in all the fibroids. I do an LDH only if there is a necrotic element to the fibroid. Okay, or if the vascular component is very high. So now you will ask, how will you come to know if there is a necrotic element in a fibroid? Trust me, it is very easy to identify it on ultrasound. Otherwise, the world appearance which you see on ultrasound of the fibroid, okay, it will have an element of necrosis coming inside. Very easy to see. It will also have a heavy element of vascularity. Okay, just in case, but again, as I said, LDH is something which is only going to have a little suspicion. LDH is something which has got no correlation to if it is a sarcoma or if it is not a sarcoma. It is just a suspicion marker, not very specific, not to be done in a 2 centimeter fibroid, which is submucous, not to be done in a 1 centimeter submucous fibroid. All these things is not to be done. Okay, that is something which you need to take home. Yeah. And this is a good question. Any comment on the growth of different type of fibroids? See, there are so many fibroids who will just not grow. Okay, you really want them to grow so that when they grow, you can operate them. Correct. But they are so adamant that they will just not grow. There are some guys who will grow very fast. 1 year it was 4 centimeters, next year it is 6. Patient is used to waiting because these days, friends, it's like that mummy logic, No, my mummy told me it doesn't really grow. And the mummy is 12th pass, and she's got nothing to do with gynecology, but still the mummy's advice is far more important than a 3000 consultant advice. So this is pretty common. But the good thing is, these days, with the amount of awareness which our generation has done as far as fibroid is concerned, even the best thing about fibroid is awareness. So we get consultations for 1.4 centimeter seedling fibroids, that what to do, shall I remove it? And you really want to remove it, but it's really unethical to go and remove it unless it is submucous. And the joke is, the ones who have submucous fibroids which are 1.4 centimeters, they want to go home and think about it. Okay, because the friend has told them that it is just 1.4 centimeters. So that's the trick with fibroids. But yeah, some of them will grow, some of them will just not grow. The thing is, in pregnancy, some of them will shrink. Okay, around 33% of the fibroids would shrink in pregnancy. 33% of them would stay the same in size, and 33% of them would grow in the pregnancy. But apart from that, I think as consultants, we should not remember anything else about the growth of fibroids.
So moving on, Jay, what about management of fibroid? These are the questions.
Yeah. See, one thing is very important. If the number of fibroids exceed 5, okay, then your risk of recurrence of fibroids has to be mentioned explicitly and clearly to the patient. Let's say if the number of fibroids are 20, okay, then the recurrence rate is close to 20%. This is what you need to sort of mention and inform your patient. Okay. What problems can be anticipated in pregnancy if a large subserous fibroid is not operated upon? It's simple. Yeah, you can have preterm labor basically, and this is something which is very common. So that's why I said, in today's time and age where talent is available so cheaply, one should get use of that talent and get these fibroids. If they are necessary to operate, then operate it. Okay. Madam, I want to tell one important point about the consent. See, if it is a solitary fibroid, and if you are a good guy who is experienced in doing the surgery, okay, then it's fair enough to do a laparoscopic procedure and not mention about hysterectomy, okay, as a part of the consent. Because hysterectomy consent is not to be taken down when you have multiple fibroids. That is a very important rule which people need to keep in mind. Okay, just keep that important point in mind because often people ask that question. Robotic versus routine 2D laparoscopy versus 3D laparoscopy. It really depends on how stupid the patient is in front of you. So if it is a very fancy patient who knows nothing about surgery, they only know that robotic surgery is good. They think some robot will operate very nice. Just put them for robotic surgery. Don't bother. If you think the patient is a good patient, uh, you know, they may have some gratitude at the end of surgery, then maybe you can consider 2D laparoscopy or 3D laparoscopy, depend upon your show of quotient. If you think that you really want to show off to the relatives, then maybe you can put a 3D glass, and they can put a 3D glass and they'll feel like a movie experience. So 3D is good. If you think you don't really want to do that, then 2D is good, because really it doesn't matter as far as a laparoscopic myomectomy is concerned. Where it really matters when it is a laparotomy. Okay. So again, I think my generation has done a fantastic awareness in putting it in the heads of the patient that laparoscopic surgery also does a complete surgery. So that wonderful tagline which people used to follow around 10 years back when I started practice. If you do laparoscopy, 50% of the fibroids will remain behind. Okay, so that's why you should do laparotomy. That tagline is gone. Most of those guys are now only attending conferences because they have got no work remaining, because that work which was being done with laparotomy is now shifted to laparoscopy. And unless they've upgraded their skill set, okay, to do the laparoscopic surgery, it's not going to come in. Okay, but yes, I want to again mention one point. See, there is no shame in doing laparotomy for a large fibroid, 30 centimeter, 32 centimeter, 33, 34, 25 centimeters. See, I know of guys who are doing excellent, those Fanon style incisions, and the patient goes home in like 24 hours following a Fanon style incision. Okay, and the fibroid also comes out in 25 minutes. Okay, that is one place where even laparotomy, that means doing an open surgery, is viable. I mean, there is no harm in doing it. Absolutely no harm in doing it. Patient also doesn't really mind. Uh, I would again go back to the point of consent, because I think these days it is important to take consent for power morcellation from the patient. See, again, there's a lot of stuff as far as the media is concerned. Oh, power morcellation was done, definitely you are going to have this. Oh, power morcellation was done, definitely you are going to have dissemination of fibroids and sarcoma and all these types of things. So that is just one thing which you should take an added consent. There are many people who, again, as I said, many of these wannabe patients who don't understand anything about anything, but they will not give you consent for power morcellation. Okay, so it is completely their bad luck. They will end up doing a mini laparotomy, and you will be knocking that fibroid out, or you will be taking that fibroid out through a colpotomy. Okay, but just remember that this is a consent which you should take. Okay, I mentioned about leiomyosarcoma and also spoke about leiomyosarcoma in my video. I mean, in the live surgery today, where I mentioned that if you open the capsule, you have already upgraded the leiomyosarcoma. And if there is leiomyosarcoma, the treatment of choice is not to excise the leiomyosarcoma. The treatment of choice is to do a laparotomy, take out the fallopian tubes, take out the ovary, take out the uterus. Okay, that is the treatment of choice. Okay, so that is one thing which people should keep in mind. And I think once you see a leiomyosarcoma, you will never ever miss it. Okay, if you see a leiomyosarcoma once in your life, once, okay, the next time you see a leiomyosarcoma, you will 100% tell that this is a leiomyosarcoma. You will never ever make a mistake, or you will never ever make a mistake in suspecting that it is a leiomyosarcoma. Okay, so that is one thing which people should understand. You can't really say that I am going to be using a, more safe bag, or I'm going to be using an endo bag and morcellating the fibroid inside the endo bag so that the risk of sarcoma goes down. That is crazy. Because if it was sarcoma, the minute you open the capsule, you have upstaged the disease any which ways. Okay, and then if you have done a morcellation in an in bag, it has got no role at all. At all. So this in bag morcellation does have a role, when you have multiple fibroids, or when you want to add to the OT billing. But apart from that, in-bag morcellation for solitary fibroid, 5 centimeter fibroid. Okay. I personally think a good technique of morcellation should be enough for these type of fibroids. You should not be switching to in-bag morcellation for small fibroids.
Jay, I've also noticed that when in your surgeries for myomectomies, you have a very bloodless field. You don't have too much of bleeding, and that's something which most of our colleagues really bother about and also counsel our patients. So how do you manage that? Could you share
Correct.
your
So, yeah.
tips?
So, see, the standard of care is to put vasopressin. But, if you ask, I mean, let's assume Rajvi was an anesthetist. Okay. And if I were to keep her happy, then the most important thing is to stop using vasopressin, because the anesthesia people don't really like vasopressin, no matter what we say. Okay. Even if we say that I'm following a great dilution, 20 microliters in 200 ml of fluid and then injecting it in the capsule without going in the blood vessel, that is great. I mean, there is no question in that. But that is not something which our anesthetist really likes to do. All right. So probably using a temporary clip over a uterine or a temporary ligature over a uterine. See, I know that there will be some or the other level of evidence which will tell you that, oh, don't clip the uterine. If you clip the uterine, it will affect the fertility. Okay. And there will be papers which will be presented for that. But you know how these papers are. Every 3 years they'll change. Okay. So then 1 year they'll be like, oh, it affects the fertility. Then a further review will come that will say that it doesn't really affect the fertility. Then a review will come that, we don't really know if it affects or it doesn't affect. And in that entire saga, 10 years will go. Okay. See, commonly just remember one thing. If you coagulate the uterine and not cut it, okay, then collaterals would really develop immediately within the next 48 to 72 hours. So somebody can ask, you have a bunch of guys in the country who absolutely believe only in pulling other people down. Okay, so a bunch of these guys can, ask people that, really, have you done a second look laparoscopy and found out if collaterals actually develop? Okay, nor will these guys have any data to concretely say what they are saying. But if you give them the data that, no, yeah, if these people become pregnant, they deliver, then they'll be like, why did you not publish it? As if they have 500 publications, So one thing you must remember, as far as practical experience of life is concerned, okay, it doesn't really matter. Very honestly speaking, it doesn't really matter. But yes, the take home point is, if you are comfortable with vasopressin, you use vasopressin. Okay, you maintain peripheral pulsation nicely. Okay, speak to your anesthetist about it. It's important. Okay, otherwise, in an otherwise normal situation, you can do a temporary clipping of the uterines if you're comfortable opening the retroperitoneum. If you think opening the retroperitoneum is reserved only for 2-3 self-proclaimed stalwarts in conferences, then that is wrong. It is a basic surgical skill. It hardly takes 1 minute for anybody to go and open in the retroperitoneum. Okay, go to the uterine, coagulate, ligate, or clip it. It takes 1 minute. Okay, so I'm sure we all have that 1 extra minute for our patients, because any which ways we are taught to not look at the time when we operate. Okay, though we may look at the time when others operate, but when we are operating, we are taught to not look at the time. So in that bargain, we might as well spend 1 minute going to the uterine and doing whatever we have to do to that uterines. Okay, and trust me, these techniques of doing whatever, ligation, clipping, these are really easy techniques. So if people may say, "Arey, Jay is saying it is easy because he is a great laparoscopic surgeon," I really don't think so. It's a matter of practice, and I think people who practice that thing of tying the knots really end up doing well. Trust me.
Right. That was a very good take home, Jay. And quickly, what if you had to deal with such a patient where she's had recurrent pregnancy
Yeah,
losses, and you can see this is, an intramural fibroid, and it's
yeah,
indenting the junctional zone slightly here.
yeah, yeah,
What would you
yeah.
do?
Yeah, intramural fibroid indenting the junctional zone. The patient, as you mentioned, has had 4 mid-trimester abortions. Okay, in that situation, life is again very simple. Go ahead and remove that fibroid. See, remember, today I'll just give a short 1 minute example. See,
Hmm.
today we saw a patient in whom day 3 embryos were transferred. Okay, poor quality day 3 embryos were transferred. Okay, in 2 IVF cycles, both the IVF cycles failed. Okay, then the patient was asked to do 3 sittings of LIT. Okay, then the patient was given IVIG prior to transfer. Then the patient was given 1 shot of tacrolimus prior to transfer. Okay, so I mean, the answer to that question is very simple. The patient had poor quality embryos, and poor quality embryo meant that the patient would not become pregnant. As simple as this, right? You can't really end up doing those type of things when the cause in front of you is obvious. Correct?
True.
Same thing with this fibroid which you mentioned, madam. The cause is in front of you. Okay. And if the cause is in front of you and you don't want to go and remove it, then I think even God cannot help that patient, because that patient is destined to suffer. Okay, so it's as simple as that. There is really, honestly, really no rocket science in that. Absolutely no rocket science in that.
Right. This fibroid is like the elephant in the room, no, Jay? I mean,
Yeah,
you can't really ignore it. But
yeah,
these fibroids, Jay, are the ones which are very difficult to actually locate
yeah,
on laparoscopy.
yeah.
So for this patient, the hysteroscopy did not show any indentation. Obviously, the serosa again did not show any bumps. So just wanted to point out that in such patients, we use intraoperative ultrasound. We've used it many times when you've been with us as well, Jay, and that
Correct.
helps sort of locate the fibroid and remove it successfully.
Right. I think the video which you are showing is one of the videos where with the especially the hand movements. No, in that video it seems to be my hand movements, but I
Right,
don't know.
right. So that's what we've used intraoperative ultrasound
Yeah,
to remove this fibroid.
correct, correct.
And what about this, Jay? I mean, this type of a patient, so you can see the endometrium here, and there are fibroids studding the myometrium, and also there are submucous fibroids as well, and there are multiple. And just in this angle, you can see almost about 7, 8 of them. And in another, there are.
Usually these girls don't do well, madam.
Hmm.
No matter what you do, they don't do well as far as the fibroids are concerned or recurrence is concerned. So if somebody is really those wacky types, coming and telling you, oh, I love my uterus so much, something like that. Yes, very good. So we'll preserve the uterus in a manner that you think you have a uterus, but actually there isn't one, something like that. And ultimately, I've seen that people who do that also develop recurrences from the round ligament part of the fibroids or from the lateral wall which is remaining. And then you have to go and operate and remove those fibroids, which is again a nightmare. So, best option, see, if the fibroids are so plentiful. Okay,
Hmm.
we really, all of us, including me, okay, we have this itch when we remove 35 fibroids, we want to post a Facebook photo on it. Okay, that I removed 35 fibroids. I charged only 35,000 like an idiot, but I removed 35 fibroids out of that. Okay. The thing is, patient will have a recurrence in the next 1 year, because when you have removed so many fibroids, there are so many fibroids which are at that age group of zero point 0.3 to zero point 0.2 centimeters, which you couldn't see. So,
Hmm.
which were not removed, which you left behind, and those ones will start growing. It is probably an inherent tendency of the patient to develop these type of fibroids, to be honest, and
Hmm.
maybe that's why this happened to this lady in the first place. So this is something which really requires a good, strong counseling to be given to the patient, and if you do that, then probably life for the patient and for the consultant becomes easy, is what I think.
Okay. So you mean to say more the number of fibroids, more is the risk of recurrence?
Yeah, I mean, that's a no-brainer, madam.
Right. And what is the advice you give to these patients if the cavity is opened post-operatively? When can they again get back to planning pregnancy?
2 3 months is okay, madam. See, opening the cavity is a great thing, to be honest with you. If there is a large fibroid and if you open the cavity, then some amount of the blood which would otherwise get collected in the myometrium and causing weakening of the scar. Okay, if the scar tissue has, if your closure is not complete, okay, then that amount of blood would simply leak out through the cavity. Okay, we do no longer go and close the cavity, or we, suture the cavity with those 4030 Vicryl and all those things. That's no longer done. The cavity would simply heal on its own.
Right. And, many of our patients who undergo myomectomy, where the cavity is opened, their common question is, what is the risk of scar dehiscence once they are pregnant? So is there any, subgroup of patients where you would expect a higher risk of scar dehiscence in pregnancy or during
No, no.
nothing?
Honestly, there is no. It really depends upon the technique of your closure. So if the closure technique has been followed nicely, okay, then if there is no dead space left inside, then the healing is very good. And once the healing is very good, life is very good. So no need to worry.
Okay, what about such a patient where maybe you would have to, make multiple incisions to sort of remove all these
No,
fibroids?
so in these guys, we try to do like a vertical midline incision on the uterus. Okay, and tunnel it and remove all the other fibroids through those tunnels.
Okay.
Yeah.
Okay. And so, Jed, these were wonderful take homes. As to, you were very clear that we need to operate on a submucous fibroid. That's a no-brainer. And the larger the intramural fibroid, and you mentioned more than 5 centimeter in size, maybe it is worthwhile operating on. And we should be using ultrasound to give the right information to the operating surgeon, because what the operating surgeon really wants to know is what is the type of the fibroid, the position, the number, the size, the proximity to the junctional zone, whether it is distorting the cavity, a 3D scan pic, and what is the distance from the serosa if it's a deep intramural fibroid. And we also use elastography in patients just to see what is the firmness of the fibroid. Also, another important take home is when you are doing an ultrasound, we need to differentiate between an adenomyoma and a myoma, because this is a common confusion. And if you are going to give a diagnosis of a myoma when actually it is an adenomyoma, then of course there are issues in the surgery and bleeding, and you don't really get the plane for scooping out the fibroid. Another important take home is when we should wait and watch, when we should do an LDH level. Importance of counseling. Jay was very clear, take a consent for power morcellation. And also he gave us wonderful tips on, improving the quality of the surgery. And Jay, one more question I have here is, many patients say, can we take vitamin D? Does this slow down the growth of the fibroid? So what is your take on that? That's a common question I get asked.
It doesn't do that on Earth, at least. Yet to know about the other planets, but I have my doubts as far as Earth is concerned.
Okay. And do we have any other questions? Or I think we've 35 minutes into the session, and otherwise we'll close. Any other take homes you want to comment on,
So I
Jay?
want to comment also on two of the most stupidest procedures ever invented. One is HIFU, that is highly intense focused ultrasound, which is MR guided basically. So fortunately, insurance doesn't cover it anymore in any country, which is a good thing. So at least if you don't believe me, you should believe the insurance people, okay? Because they are wiser. They don't really want to end up paying for such type of procedures, because the recurrence rate is very high and it doesn't dissolve anything. The great thing about HIFU is that it doesn't dissolve anything. Okay, it only does volume reduction. So that is one thing you have to keep in mind. And second is uterine artery embolization. Oh God, it is such a fad. I mean, uterine artery embolization. What is it? It's something where you try to put, those plasma spheres going through the uterine artery. Okay, and you think that the fibroid will dissolve. I mean, really, So, uh, we have these wonderful forums where people really like to critique a gynecologist who is doing fistula work, right? In fact, a gynac will only go and complain against the gynac doing fistula work. Actually, if people in some of the national bodies, just in case they have the guts, they should form a consortium to launch a campaign against interventional radiologists promoting uterine artery embolization. I mean, the guys are not qualified to do anything apart from putting or passing those guide wires wherever they want to pass. Okay, but definitely uterine artery embolization should not be promoted as a method which cures fibroids. Yes, it is a reserve line. It can be used when the patient is unfit for anesthesia. Okay, and it may help, but it really screws up the fertility. Okay, so just in case you think you will do a uterine artery embolization and the fertility will be excellent, so there's no such thing. It screws up the fertility badly. Okay, because it causes a lot of damage to the basal endometrium. Okay, and that is one thing which should be a take home. Like, strongly discourage this procedure unless the patient is unfit for anesthesia. I mean, it's so rare to see a 35-year-old girl who is unfit for anesthesia. I mean, I've not seen that, probably one case in 10 years of my practice. Of course, I mean, I have very limited practice and I'm only into 10 years of practice. But I am also counting in guys who have a huge practice. I don't know how many times you would have seen this, right? So please, don't really don't end up promoting these type of things. That, okay, do uterine artery embolization. I mean, people still need a lap myomectomy, and people want to do uterine artery embolization for a 45 centimeter fibroid. How will it work? I mean, I don't know. So as I said, my knowledge about that is very limited. So is my experience about gynecology. But in my limited experience, I have found out that this is one of the most crappiest procedures ever. So I think it's a very important take home point. As consultants or as clinicians, we must give this message to our patients. Okay. Even if they don't get operated from us. Okay. We must give them this message, is what I think.
So no HIFU, no medical management is a big take home. But then, Jay, there are some patients, just before an IVF cycle when the fibroid is not really distorting the cavity, but then you want to give a GnRH.
As I said, there are some indications for giving medical management. Correct. Right. Like, let's say a 3 centimeter fibroid and somebody is getting worried about it. Right. Maybe you can give a depot. Temporary, there is a volume reduction. Correct. But it is again temporary. It is not a permanent volume reduction. Correct. Rather than giving ulipristal, giving a depot is better, is what I think. Absolutely. Rather than giving mifepristone, the hit thing, fibro ease, it doesn't ease anything from anywhere. Okay, rather than doing that, giving Zoladex is better, is what I think. Okay,
absolutely right.
But that indication is limited. Okay, that indication is very limited. One can't really extrapolate it and say, oh, I had a 24 centimeter fibroid and I wore a sexy sari and it just disappeared. How? I mean, really, it was not 24 centimeters, it was 2.4 centimeters. That means, so that is something which I think people get carried away with. And patients get carried away with because patients want non-surgical options, right?
Mm-hmm. Very clear, Jay. And I think we just have one last question. And Jay has answered role of LDH.
Yeah, we've answered it.
Yep. So that was a wonderful session, Jay. Thanks. Lots of take homes, right from diagnosis to management and common mistakes made. And I think all of us have really benefited from this discussion. And thank you everyone for joining us. 130 people plus have joined and it was wonderful. And I think today is Shivratri, so you're going to stay awake?
Trying to.
Super. So good night. Bye, Jay.